continue on presenting our speakers. And our next speaker is a very good friend of mine, Rafael Blanco. Actually, he likes to travel. He was in Spain and he went to London. He did some work in London. And when he has some time, he discovered some blocks, PEX 1, PEX 2, and then he looked at the abdominal wall and he discovered and he described the quadratus lumborum blocks. And then he invented some ideas regarding fascial plane blocks all over for chronic pain. And he likes to travel, so he was in Spain, then he went to London, and then from London he came to Abu Dhabi, where he also travels from different hospitals. He started with the lead in the Corniche Hospital, obstetric hospital, where he published a lot on obstetric patients. Then he joined the military hospital to treat severe injured patients. One of them is this morning. He was doing a craniotomy this morning, and he came all the way from Abu Dhabi to us to deliver his nice talk on fascial plane blocks in chronic pain. Thank you, Rafael.
Thank you, Mark. Can you hear me well at the back? Yeah? Yeah, it looks like I'm traveling all over the place, but I tell you, I spent 20 years in London, so I don't move that often, but unfortunately I'm getting older. That's what it is. So thank you for the scientific committee. Thank you to the whole panel, the directors of this meeting. And thank you for all of you to come and listen to me. Considering this is slightly strange, but I think part of your armamentarium techniques these days that are the so-called fascial plane blocks. So, no conflict of interest, okay? Simple on that one. Now, when we're talking about fascial plane blocks, we have to concentrate mainly in the thorax and in the abdomen. If you want to be really, let's say, very precise about it, a fascial plane block is any block that involves distribution of local anesthetic solution into a fascia. Yeah? But most of the blocks that we describe, I describe, and I use in my practice for so long by now, nearly 17 years, are concentrated in the thorax and the abdomen because that's why it was needed for me. So if I showed you here this cross-section at thoracic level, it shows us the importance and the influence of those very first 3 blocks that I published in the whole medical anesthesia, anesthesiology and chronic pain society. Because in less than 3 years, the thoracic wall blocks, they passed from 3 to 14, no time. You know, it was literally 1 block a month. Everybody was designing, and this was based basically on, I can see a face plane, I will put a needle there, I will label a new block on this. So you can see how it's getting a bit complicated. Now the importance of all of this is how useful it is, isn't it? It's not about describing, it's about giving solutions to our patients. So if I try to move now into what it all means in terms of anatomy cross-sections, and I concentrated in this case, for example, into the axilla, it is a no-brainer when you dissect a cadaver to see that there's a lot of junctions or cross-junctions of nerves in different spaces, or fascial plane spaces. In here, you're looking at the axilla, at the top of the axilla, and what you can see here is the axillary crus. This is what we call the axillary crus, because you see the intercostal nerves, the long thoracic nerve, and also you see other nerves proceed, like long thoracic nerve and thoracodorsal nerves. So it's a no-brainer that if you put local anesthetic over here, you will have certain effect. What is the problem? Now, in this case, you see that all the fat has been removed. So that's why it looks really empty and really big. So, and this is exactly the main problem with fascial plane blocks. They are volume dependent. At least from the logical point of view, they must be volume dependent. So, you can see here, and just highlight part of the blue dye and how it stings all these nerves and structures. I'm not going to stop in each of them, but you can see the extension of the contamination of methylene blue is pretty dispersed. What is the effect you get? This is one of the very first papers that I published. This was about the serratus plane block that affects the lateral side of the hemithorax. And you can see this sensory mapping how the local anesthetic in the right space, it produces a very, very extensive effect. This can be applied not only in acute pain, but for sure, and I will prove you soon, also in chronic pain and situations. What is important about here, and I wanted to concentrate on the sensory mapping of all of this, is pretty clear, what these blocks extend, either anterior, lateral, or posterior. In this paper also, we did a study with gadolinium, and you could prove the massive distribution of the gadolinium anterolaterally, lateral posterior as well. So the effect was going to be there. So it's not discovering, it's a little bit more than, I would say, designing. Yeah? There was nothing much to discover, just to design it. In 3D reconstructions, it gives you a different switch, a different way of seeing, understanding what you can do with these blocks. And when you can see more laterally, you can even count all the intercostal spaces that you can be using this. And when you're talking about thorax and chronic pain, obviously you have pretty clear ideas, some of the indications you're going to be using these blocks for. You can see here from 2 to 6, easily extending and covering, and 2 levels. This is a dual block. Now, if you look now at what I said to you about thoracic wall blocks, and how it became from 1 to 2 to 3 to 14, it's kind of confusing to see what is the relevance of these changes in the sonoanatomic images we obtain. These blocks, these 6 blocks, refer only to the anterior aspect of the hemithorax. And when you give this to a child, that always is the best thing to do. You give a 5-year-old child to look at this, and they will hardly see any difference in them. But we created a series of blocks depending on how we put our probes, yeah? And literally based on a millimeter up, a millimeter down. And remember, fascial plane blocks are a type of block in which the minimum of 10 mils to 30 mils are injected into that plane. So it makes you wonder if 1 millimeter in depth is going to be affected, how it's going to be affected by 20 mils of local anesthetic. So here, it's a little bit different. This is the lateral side of the thorax, and you can see subrhomboidal, no, this is posterior actually, subrhomboidal, posterior, and intercostal paraspinal. And you can see here, if you look at the labels, they all share the same, not only muscular references, but also bony references. They're really much alike, all of them. So how relevant when we're talking about thorax is for chronic pain? Well, this is a very common syndrome that you can face in breast cancer surgery. That is the post-mastectomy pain syndrome. Most of you probably are familiar in your clinics with it. And it really accounts to up to, it's debatable, but it can account up to 40–50% of your patients complain of this type of pain. So it is important to treat because the impact in the society is huge. So how do you treat it? Can you use fascial plane blocks to treat this? And the answer is yes. As far as 2016, you could see the very beginning of the use of fascial plane blocks to treat, all this type of pain in people. And in this study, obviously a pilot study at that time, you could see here how they were claiming an effect on pain relief and also an effect on the sleeping temperatures with the block. So it was highlighting that it could be a beneficial in it, and it was highlighting we should be researching even further with this. This was followed by Korean friends, and in this case they will look at the effect of these fascial plane blocks into chronic pain after breast surgery. And with breast surgery, they prove a lower incidence of chronic pain after 3 months by using routinely these blocks, so prospective studies. Again, thinking about some of the blocks, because there are hundreds of papers right now. Also, in chest wall pain of any kind, another paper showing how pectoralis nerve blocks can be affected to certain extent. In this case, we're moving from 30 days now to 90 days. And then in here, once the idea, the theory, the hypothesis that the blocks were going to be effective, that's when it came the comparison between some of them to try to understand if one of them could be better to the other one, and so which mechanism. In this paper from anesthesia, and now we're just moving to a high impact papers, you can see how they are comparing two standard blocks, well-established blocks like the PEX2 or the serratus flame block. In this case, it was working in favor of the PEX block itself. But you know, these things can change anytime. I'm sure somebody will publish something different. Post-thoracotomy pain. All of you, they are familiar with centers, thoracic centers, in which they do lobectomies, etc. You know this is a big problem. So they routinely, many of them, they are using also the serratus flame blocks for post-thoracotomy pain. And here in Pain Physician in 15, so we're talking about around 8 years ago, they were already demonstrating how effective can be used this prophylactically. These blocks are important when it comes into muscular injuries, tendon injuries, etc. Our interesting colleague from Japan, Yushima, also published in one of his multiple presentations. He also showed how the use of these blocks can be effective in latissimal subdorsal muscle syndrome, actually. Yes, and this is the one that probably you're all expecting when you see the 3D images and everything. How useful could be the use of serratus flame blocks into the upper zoster. Interesting about this paper is that, and also my personal experience, how the emergency department services are so involved and so deep into the use of this type of blocks to treat whatever comes through the door with them. So this is an emergency department paper in which it shows this is part of the armamentarium to treat this very, very severe pain that you can get. Another, I think, particular plane block that obviously I have to mention is this rectus spinae plane block. It's purely a posterior plane block, a posterior block. As I told you at the beginning, you could say there are three categories of thoracic wall blocks. There will be anterior, lateral, and posterior. These refer to the posterior. And this was published also in 2016, a little of time now, nearly we're going to be close to a decade with it. And it originally was described and it was displayed that the use of local anesthetic in the posterior part of the thorax and by leaking in between the costotransversal ligament and reaching the paravertebral space, it could have some effect, especially in chronic pain patients. This was described for chronic pain patients. 3 cases, actually. This was a case report paper with 3 cases that, as we say, how do you say this? Great brains think alike. Yes, you could see how the designing of this paper, combining 3D imaging, sensory mapping, it was showing similar effects, and similar distribution, in fact, and in this. And how successful it is. It is very interesting to see how, for me, in this paper, posteriorly is a very good spread of, in the sensory mapping way of thinking, but it is very interesting to me that this block really, it does not reach the midline, it does not reach the sternum, it stops at the nipple level. What it means is missing the anterior branches of the intercostal. So whoever claims that the paravertebral effect is a major mechanism of action, obviously didn't see this picture. I would say by looking at this picture, this is a posterolateral effect by doing a sensory. So no paravertebral effect, if you believe in the picture published. Now, You can see here how this ESP block, this is an abbreviation of this block, it was also used to treat acute pancreatitis successfully. And you can see here how also was treating post-thoracotomy pain successfully. So you will get hundreds and hundreds of papers by now claiming the good effects of these blocks. So it's something you cannot ignore for sure. Now I'm going to move from the thorax. I think I'm going to leave it there because this will go on and on based on the thousands of papers just published in this. And I'm going to move into the abdomen because this is the other part in which these fascial plain blocks, they develop really, really well. And as far as 2007, we already publishing, a technique that by putting local anesthetic into a fascial plane, we could observe good pain relief in the patients. Well, at that stage, to be honest, I have to be frank to you, we were thinking about acute pain. We didn't think about the uses of this block in there. The ones of you that are old enough in chronic pain, you know the quadratus lumborum block is a block from the last century itself. The only difference, it was done by pure intramuscular injection in those days, or on the fluoroscopy, in fact, in some of the standard old books. So in here, it was with the ultrasound coming into place in those days, it was a matter of basically labeling things rather than inventing anything. We just label, we look at things with a different view than the view of the sonographers. And you can see here possible points of injection with these blocks and possible versions of the technique itself. Now, this is very important, and I want to tell you this because when I hear in many, many places saying how difficult is this block compared to this block, we all try to follow hints or things that can help you to perform a block, like for example, bony landmarks, right? So we are very used to use bony landmarks as our friends to do our blocks, especially in chronic pain. Now, when we're talking about fascial plain blocks, my suggestion is that you don't look only at bony landmarks. You're looking at what it's supposed to be. A fascial plain block is a block in the fascias. And luckily enough, fascias in ultrasound are always hyperechoic. That means they're very white. So if you have a little bit of imagination, and if you are a good sono operator, only by following the fascial plane lines, you know where you are all the time. As soon as you understand what rod you are using. So you can see here, in between muscles, I highlight making white the picture that you have to have in your head about how, the fascias move around the body. So if you understand this image that is always there, you will have a second way of positioning yourself and knowing what is going to be your optimal point of injection for your injection. So not only bony landmarks that sometimes when you go posterior, definitely with ultrasound you're going to struggle, but if you're thinking as a fascial plane operator, you will find it much easier indeed. So if you can see here now what I mean by that, this is a sequence of all these muscles, and you see you have external oblique, internal transversus, and you can see very clearly these white lines. The only thing you have to do is to follow them, and they will limit each of those muscles you want to limit. And then you will locate your point in the part of the muscle you want to be. Superficial, deep, lateral, medial. Talking about fascial plane blocks. So you see the bony landmarks not so relevant. It's good to have a bony landmark at the vertebral body with that transverse process there that can give you a clue. But if you're using fascial planes, fascial lines, and you're a sonographer, and sonography is dynamic, that means you have to constantly move your probe. You follow the lines like a sonographer does, you know, and you will always know where you are. You see, this is a posterior move, yeah, and throughout you can label what's happening with each of these muscles, so you always know where you are, and that's how it does, you know, without bones. For the ones that like bones, okay, we're still with the bones. So this is a standard image of the QL with bones as a reference. The sandrock technique, the iris one. This is the iris block, yeah, like a sandrock with the stem of the sandrock. The Norway people, they call it the finger of God. Yeah, the finger of God means your finger points at the QL muscle. Yeah, and you can see here the finger of gold of the stem of the sandrock pointing to the QL. Very easy to know where is the muscle you're really trying to target. And finally, if you're a bit of a Viking like the Danish people, you just call it tequila, you know, because that's the inspiration of the having a bunker. So they call it the tequila block. So the tequila block, the sandrock block, or the finger of God, they're all the same. They're all sono-anatomical references to the same problem. Okay? And you can see here the vertebral body with the transverse, etc. And here you can see how they needle and how easy it is to do it. How this QL block became useful, or somebody highlighted the use of these QLs for chronic pain. So the first one I came across in the ultrasound era was this paper from Brazil, in which some of my people I know here, they were presenting how effective it was for untreatable hernia repair pain syndrome, you know, post-surgical pain syndrome. In here, I recognize some of the names here, and they are also very ultrasound enthusiastic people that they were the first ones to prove the use of the QL with ultrasound and be successful. Now here, you saw it on the ESP, how it was useful for pancreatic cancer pain. Here also somebody else comes with the same idea by using the quadratus lumborum pain. Now, my point about the abdominal wall, and this is the most important part of all of this. This paper from Ohio, from Cleveland, Ohio, by Hasan Esarkawi, a good friend of mine, a very, very enthusiast in the terms of anatomy and this type of block especially. He dissected cadavers and he used all these blocks, and he looked at the distribution of these blocks. You will find many papers, anatomical papers, trying to understand how these blocks are working with pain, because we know they work. So what he did, he compared them. Yes, he compared all these blocks that were presented. And he looked at how the dye was extending, you know, in each of these planes. And what he found, and I don't want to go very deep into the details, I'm just going to look at it in a very broad way, that for sure there was a massive distribution of methylene blue in each of them. So all of them, they show a response. They show a spread in a fascial plane in between the erectrospinal muscle and the intercostals or at the abdominal level. All of them, they show that. And many of them, they show certain leakage into the paravertebral space. But the guys or the people who have been using paravertebral blocks for, unfortunately, 30 years in my life by now, we know how tricky these blocks are and how a headache these blocks are in terms of volume. And that's why there's so many papers about them, because they never reach the perfect volume for these blocks. That gives you a clue of what's going on. What I mean by this is that, yes, some segments are affected by these blocks, but when you look carefully at the data, and what I mean by carefully, look at this image, this graphic in here, blue, red, green. Blue is ASP blocks, red, green is QL blocks. What I'm trying to point out, not at the extension or distribution of the block from T2 to L5, not at that. I'm trying to point out the circle ones, the circle areas. Yeah? Because the circle areas represent when the dye has contaminated each of those paravertebral spaces. Yeah? And you can see here that there's no difference. All of them, they move in between one segment to two segments to three segments. But it's not a clear effect. And there's no a clear big difference between them. If somebody completely looks at this, will say they're all the same. They all do the same. Yes, one segment up, one segment down, but it's three. In fact, in the ESP it says 2, 2, 3, 3. The same. What I mean by this, it means that if your position about the use of fascial plane blocks is solely on anatomical differences, there isn't any. It's a matter of choice, and you have your own preferences and particular reasons why you choose one to another, because anatomically you cannot prove a really gross difference between them. All these blocks, they do the same. And when you start comparing them, you will see minimum to no change, the difference between them. And that is the fact. The reality is this, and this is the conclusion about fascial plane blocks. There's a very, very respectable amount of evidence to show you that these techniques that are extremely easy, extremely fast, extremely safe to do, they will give you pain relief to your patients. Very simple, okay? There's enough support right now, because for the last 10 years there was always people saying there's no evidence, there's no RCTs. There are RCTs, there are meta-analysis, all this is well proven. If you are not using fascial plane blocks, you should be doing them for sure, because they are very, very easy to do. And when you are very busy, sometimes time matters. Establish well techniques, ongoing research, everybody's doing their own research. To me, fascial plane blocks, I cannot live without them. Okay? Thank you very much.
Great. So, lots of brainstorming with Rafael, always ideas. He's a pioneer. Please, Dr. Marshall. Mike, please.
You've been discussing lidocaine, which has a functional half-life of an hour or two, if I want to be generous. Bupivacaine a little bit more. Can you give us some insight how these drugs can be giving weeks and months of pain relief?
Well, this is what I was saying about the use in chronic pain. The insight is about the mechanism of chronic pain. If you really attend to the pharmacology of the local anesthetic itself, as you well said, lidocaine, 1 hour, half an hour, well, gone. But we can see there's a constant effect. In fact, some of us, we can say here that it looks like it's a clock, because I can time to the minute, you know. Well, either myself, we've done it in the past, we can time to the 48 hours mark the effect of some of our blocks. You know, in certain situations like endometriosis and QL blocks and things like that, we were doing a block, and exactly 48 hours later, the block disappeared. Or in one, depends, really depends on how the severity of the endometriosis and everything. But yes, you cannot really explain the effect of these blocks by only looking at the pharmacology. Mechanism of action, personal opinion, is my personal opinion, if that's what I want to give, just there is a direct action of the fascial planes itself.
And you're quite confident it's not a question of the systemic effect, which can last longer because the concentrations required are less. Or the real concern, I suppose, would be placebo.
Yeah. No, I'm telling you how I think. It's very confident that it's not systemic, because if you got ankle pain, I will stick my needle in your neck, I will have that effect. Why should I go to the ankle? I'll put the needle in the neck. You're clean, or even making it better, we're just thinking that intercostal plane is the space with the highest absorption of local anesthetic, correct? So you really want to see a pain, chronic pain in your ankle, and you want to see a quick effect with lidocaine, do an intercostal block and see if it works. If it does not work, it means there's no systemic effect.
And proper placebo-controlled trials.
Mm. Yes,
Do
of course.
we have really good ones, convincing ones?
Well,
Where
I don't know what you mean by-
neither the doctor nor the patient knows what was given.
I assume, that some people do their research, they follow the standard scientific methodology. Personally, I was I compared to placebo these blocks, and we were very careful about the placebo effect. And, you can always question many papers, okay, but for sure, you have to use the publications in certain way. It's not placebo.
There's one question here.
Yes. Blanco, if we add adrenaline to local anesthetic mixture in acute pain,
Yes.
this would extend the
Duration.
yeah.
Well, we all trying to understand that it's going to extend the duration, but not in chronic pain level, right? Personally, for chronic pain, in my opinion, the addition of adrenaline, it means nothing. Or the addition of dexamethasone, it does nothing, okay? Because we were the pioneers in the use of fascial plain blocks. We were trying to standardize our research. So not to create confusion, we always been using plain, single, local anesthetic without adjuvant. For sure, there were papers coming later that they demonstrate the extension of duration of action, but at acute level, When I saw the use of all of these at breast surgery, and the effect over the 24 hours, 48 hours mark, yes, there was extension in all of this, but not.
One question there.
Yeah, thank you very much, Rafael, for that brilliant talk. I had the fortune of, those of you who may not be aware, Rafael was at his peak a few years ago in London when he was inventing all these blocks. And you might still see some videos of him actually needling his friends and his friends needling him and videoing it. My question really was, Rafael, I've done quite a few of these erector spinae blocks. I wanted to know what your views were on some of the newer modifications of the ESP that we are seeing, because the original plan was you hit the transverse process. Now there's talk of sliding anteriorly off it and going a bit forward. I just wondered whether you had any specific thoughts.
To me, I have a very positive view about all of this. Because to me, what it means, people are still trying to understand and they're trying to improve their blocks. It's a natural process. It happens with every single block. You could see in the next blocks, we moved from 1 to 2 to SPB. There was a natural transition to improve the quality of the block. So they're trying to see if there is any difference between these points. Personally, as I said, when you inject 20 mils of local anesthetic and you are changing a landmark by 1 millimeter, 2 millimeters, by common sense, I found it really hard to believe, it really matters that much, 20 mils of local anesthetic, 1 mil distance from one point A to point B. You do dissections. I showed you a dissections of the axillary, yeah? Well, I showed you dissections of the erector spine plane itself by Hesson. You could see the massive spread of blue dye throughout, from T2, T3, all the way down to L5. Massive spread. If you really want to believe that moving the needle 1 centimeter is going to help you to reach T1, well, that's you, but to me, the answer is so clear that sometimes I'm getting very amazed.
Great.
I have one question. Super.
Sir, we will have more questions in the coffee break because we are running late. We're running late, like half an hour. So you can ask your question outside in the coffee break. We'll resume after 15 minutes, please. 15 minutes.